Good morning, everyone. Welcome to Living Sickle Smart. My name is Ray Blaylark. I am the president and CEO of Sickle Cell Foundation of Minnesota, and we are so incredibly excited to bring to you this next session of our Living Sickle Smart series. This month, the month of October 2021, we are focusing on sickle cell treatments and curative therapies, and we are very thrilled to have one of our own local experts in pediatric sickle cell at large, Dr. Stephen Nelson. He is going to be presenting. And so without further ado, I'm going to let him make his presentation. And then at the end, we will have a few minutes to chat with him about some of his experiences in sickle cell and treating children with sickle cell disease. So Steve, I'm going to turn it over to you.
Great. So let me see. You can start sharing, all panelists. There we go. So that's not what you want. All right, can you see my slides?
I sure can.
Great. Perfect. All right, so thanks for inviting me to speak. And I think over the next 20 minutes, we'll do a brief presentation of our treatments that are available for sickle cell disease. There are lots coming down the pipeline, but I want to focus on the most common ones. So first, just a brief overview. What is sickle cell disease? It's an inherited disorder of the red blood cell. Red blood cells, what has hemoglobin in it, that's what carries oxygen to the body. The red cells have an abnormal shape, so they plug up blood vessels, and that can lead to tissue and organ damage. I think it's important to review this a little bit so that we know what our options are for treatment. A normal red blood cell lives about 4 months. It's nice and round. Sickle cell, the red cells live maybe 10 or 20 days. They're very rigid. They look like a sickle that you'd cut wheat with. And they block blood flow. So this schematic, I think, is helpful. So red blood cells carry oxygen around to the body. That would be red because there's oxygen there. The red cell gets in the tiny blood vessels and it delivers its oxygen to the tissues, and then it squeezes through the small blood vessels and goes on its way back to the lungs to get more oxygen. In sickle cell, you can see that the sickle cells can prevent the blood from even getting into the small blood vessels. Those that do get in the panel at the bottom, once they deliver their oxygen, then the cells sickle. And it's that sickling and clogging up these tiny little blood vessels that leads to the myriad complications of sickle cell disease, most commonly pain, but also damage to the organs. So there are many manifestations of sickle cell disease. Some of the manifestations are related to what's called hemolysis, the red cell only living 20 days. That makes your hemoglobin low, that's anemia. That can lead to jaundice, the yellow color of the eyes. That builds up and can cause gallstones. It can make the blood pressure in your lungs go up, which can be a serious problem. And then the other issue is that those red cells are abnormal shape and they plug up the blood vessels. So this vaso-occlusion, or blocking up blood vessels, can lead to pain, stroke, makes your spleen not work, or your spleen can get very enlarged and can cause acute chest syndrome, which can be very serious. So there are a lot of targets for potential treatments, as you can see. I like this slide that I borrowed from Global Blood Therapeutics site, kind of a pyramid of treatments and complications. You can, at the top of the pyramid, would be addressing the root cause of sickle cell disease. And that can be getting a new bone marrow. So now you make normal cells, or changing your genes. We know where the genetic defect is, gene therapy. That would be a root cause. We're going to talk about a drug called Oxbrida or voxelotor, as well as Hydroxyurea, that work a little bit upstream. Neither of them are curative, but they work upstream to try to prevent the sickling of the red blood cell. Other treatments are downstream. the sickling has already happened, the blood vessels are already being occluded, and that can lead to pain, increased blood clotting. Adhesion means sticky. The red blood cells are sticky to the blood vessel. And then there's some treatments that affect decreasing the stickiness, some treatments that might decrease inflammation. Some of that is something as simple as ibuprofen. Some people are trying blood thinners. And then other things that can affect the red blood cell are what's called oxidant stress, and then glutamine or Indari is FDA approved, and that has been helpful in some situations, but it's not addressing the root cause. It's kind of dealing with symptoms that are already happening. So one of the most important interventions, it's not really a treatment, but one of the most important interventions for sickle cell disease was newborn screening. And it's been around for over 40 years in some parts of the United States. But testing early, educating families, intervening early, I think is of critical importance in sickle cell disease. So in general, there's kind of 4 approaches, if you will, to manage sickle cell disease. One is to do nothing. And I say nothing in quotes, but basically that means take your penicillin until age 5, hydrate yourself, dress appropriately, try to prevent pain, come to all your clinic appointments and get your screening tests done to try to keep yourself healthy. But really, you're just addressing complications as they happen. So that is one way to manage sickle cell disease. It's not what we would recommend. Or you can do something proactive to treat the sickle cell disease. One would be hydroxyurea, which we're going to talk about. There are, I say plus or minus Indari and Oxbrida, as those are FDA approved. You can get a blood transfusion every month. That can certainly decrease your sickle cell level. There are lots of complications with that. It's not something we do routinely. There are certain situations where we absolutely would recommend transfusions. Stem cell transplant can be curative and has been approved for quite some time. The downside is not everyone has an appropriate donor for a stem cell transplant or bone marrow transplant. There are potentially many complications from that. Some emerging therapies are trying to improve how we use hydroxyurea, which we're going to talk a bit about, gene therapy, which we're going to talk a bit about, and then Adacthio, which some of you have probably heard about, and we will also talk about Oxbrida. So first, hydroxyurea. So to understand how hydroxyurea works or why we would give it, let's think about hemoglobin. Hemoglobin is what carries oxygen around to the body. And before we're born, we have hemoglobin F. All of us have hemoglobin F. And then we're born, then birth happens, and we stop making this gamma chain, and we start making beta chains, and that's hemoglobin A. And that, around 6 months is where the lines cross. Usually by 9 months to a year of age, most of us have no hemoglobin F, and all we have is hemoglobin A, unless you are a carrier for sickle cell trait, then you have about 40% S. And if you have sickle cell disease, then instead of making A, you make hemoglobin S. So we know that babies don't have troubles with sickle cell disease. So if we can intervene and keep the hemoglobin F level high, that can be very helpful. So what hydroxyurea does, you take your hydroxyurea, it does a lot of things. It increases the hemoglobin F, but it also lowers the platelet count. Platelets are what keep us from bruising and bleeding. Usually the count is very high. Those are sticky and help clog blood vessels. It also lowers the white blood count. Those are our infection fighting cells. And those are also very sticky and can cause blood vessel obstruction. So we want those numbers to be lower, but not too low. So you have to get your blood work done. Hydroxyurea also has something called nitric oxide as part of the molecule. Nitric oxide is very important in opening up our blood vessels, especially in our lungs, but really anywhere. So hydroxyurea does a lot of great things. It increases your nitric oxide. It makes your hemoglobin F higher. It lowers your platelets and your white blood count. That's great. The red blood cells get bigger and juicier, which means they're softer and squishier and they can swim through blood vessels. The reticulocyte count, those are your new red cells, is decreased because you're not having to make them as fast. And we know patients live longer, you have less pain, less complications. The biggest advantage is it's taken by mouth and it's just once a day. So what about using hydroxyurea in infants? I'm a pediatrician, we want to intervene early. Let's start it before the F level drops. And the NIH most recent guidelines, the American Society of Hematology is coming out with newer ones. It'll be interesting what it says. But should we consider, offer, recommend, or treat every infant? The evidence-based guidelines that came out in 2014 is a busy slide, but it said we should offer treatment to everybody 9 months of age or older, regardless of their clinical course. And actually, we recommend it. Offer means we discuss it with the family as an option. Recommend is we discuss it with the family and recommend that you actually start it. And we've been very aggressive at children's, starting as young as 5 months of age. This is a paper we reported was published just over 2 years ago. And you can see the authors there. You recognize many of the names there. Cohort 1 are the infants that we started during infancy up to 12 months of age versus cohort 2 were kids who started between 1 and 2 years of age. And cohort 3 were kids who were hydroxyurea was started after 2 years of age. And what you can see, blue are the youngest kids, the younger infants. You can see their hemoglobins were much higher than when hydroxyurea was started later. The number of hospitalizations was significantly less. The number of transfusions was less. The number of pain crises was significantly less. So the outcomes were much better. And this is most likely related to the fact that the baby hemoglobin, the hemoglobin F, stayed around 30% as opposed to dropping. And the higher this number, the better. So starting hydroxyurea early is important, but it is still underutilized. There are many reasons. I'm going to be presenting on racism and bias, and that's some of the issue, providers not offering it. There's also fear of the drug. It was initially developed to treat cancer. So there are many barriers to hydroxyurea use, and I'm hoping we can break down those barriers. I love this report from about 6 years ago, looking at the 4 options we talked about. No treatment, just, do the best you can. Hydroxyurea is HU, CT is blood transfusions, chronic transfusions, and this one is stem cell transplant. And this is what's called a Kaplan-Meier plot. So it's survival, how many patients were still alive in 15 years. You can see the lowest survival actually was stem cell transplant. And many of those deaths were early and were results of complications from the transplant. The next best was no treatment. And then the treatments that had the best survival, they were very close, almost tied, almost all the patients were still alive 15 years out, was getting a blood transfusion every month versus taking hydroxyurea every day. And between the two, hydroxyurea therapy is much safer. Getting a blood transfusion every day, every month, brings with it significant complications and other problems. So hydroxyurea is great. It's still one of the best things we have. And one of the emerging therapies, if you will, is trying to dose hydroxyurea more accurately. Not everybody needs the same dose. You want to be on the right dose to get the best effect, but also to not have significant complications such as dropping your other blood counts. So we at Children's and several other institutions across the country are part of what's called the HOPS study. Patients come in and if they agree to be on the study, they get a single dose of hydroxyurea in clinic and then get some blood samples done before 30 minutes after the dose, an hour after, and 3 hours after the dose. And we send those samples off to Cincinnati Children's, and they can predict what is the best dose for this individual patient. And then we can start at that dose right away and get the best responses possible. Historically, what we've done is start at a very low dose and increase the dose every month or two. And sometimes it can take 6 months or a year to get to the right dose for that patient. So this is very exciting. Gene therapy. There are open gene therapy trials for sickle cell disease. These are very exciting. There's many different ways to do gene therapy, but there's something that is the same for all types of gene therapy is you do need to get a single dose of chemotherapy, something called busulfan, which can have some side effects, but nowhere near the side effects or risks of having a bone marrow transplant. Gene therapy trials are exciting. It's something that I would recommend you discuss with your provider. See what trials are open. Are you or your child eligible for the trial? Once the gene therapy is FDA approved, then it would potentially be open to every patient. So it is something to consider. Next is going to be Adakveo and Rivapansel. Adakveo you've probably heard of. It's an IV infusion. It inhibits something called P-selectin on the white blood cells so that the white blood cells don't stick to the blood vessel. There are several drugs that can block this P-selectin. Rivapansel is similar to Adakveo. It's IV infusion. It's being studied when patients are in the hospital having a pain crisis to see if it can shorten that pain crisis. Crizanlizumab or Adakveo is currently available, FDA approved for patients with any kind of sickle cell disease, 16 years of age or older. It is an IV infusion over 30 minutes. It is approved, you get a dose and then another dose 2 weeks later, and then monthly for a total of a year. And what this was the initial study called the SUSTAIN trial that compared just placebo or just sugar water versus low or high dose Adakveo. And what you can see in the high dose arm, this stands for sickle cell related pain crises. The number of pain crises was cut in half in patients on the high dose Adakveo versus placebo. So that is the dose that has been approved. There are some side effects. You have to get an IV done. You have to come to the infusion center. Mostly it's well tolerated, but some patients have some achy joints, some diarrhea, some itching, vomiting, chest pain has been reported. Most of these are while the infusion is taking place. But it can work. It does decrease pain crises in half. But again, this is a downstream treatment. The pain's already happening. The cells are already sickling. This is kind of a reaction to the cell sickling. But I think it is a good option for many of our patients who are having frequent pain. So ask your physician about it. Hopefully over time, we can use it in younger and younger patients. The other drug that is currently FDA approved is Oxbrida or Voxelotor. It's a medication by mouth that you take once a day. And what it does, it binds to the hemoglobin so that it holds on to oxygen better. We know that hemoglobin S, sickle hemoglobin, doesn't hold on to oxygen very well. Oxbrida improves this and makes it almost normal. And with more normal oxygen levels, the cells don't sickle. The HOPE study was published in the New England Journal of Medicine, which led to the FDA approval a couple of years ago. And you can see the higher dose versus medium dose versus, again, placebo, a sugar pill. And patients on the higher dose had significant increase in their hemoglobin. More than half of the patients had an increase in hemoglobin of at least 1 point. About a third of patients had hemoglobin increase over 2 grams. So this is working a little bit upstream. Let's prevent the sickle cells from sickling, so that they live longer, they don't break down, and they don't obstruct the blood vessels. For our younger patients, 16 and younger, where we worry about stroke, you may know your kids come in and get TCD testing done. We know that Oxbrida can help normalize TCD, which is blood flow in the brain, and help prevent stroke, which is very exciting. So we know that it improves hemoglobin. The red cells live longer, so you're not as jaundiced. Although on the initial study, there weren't enough patients, it appears that it helps prevent pain. More study is needed, but I think that will prove to be the case. And there's some promising observations in blood flow to the brain with TCD results improving. So again, treatments that are more upstream, preventing the cells from sickling. We've got gene therapy trials happening, certainly bone marrow transplant. Talk to your providers. Oxbrida and Hydroxyurea are currently FDA approved and available. Oxbrida is for 12 and older, and this will change over time to younger patients. Again, talk to your provider about the potential use of these. Then downstream, Adakveo, crizanlizumab is the only one that's FDA approved, but and glutamine and Dari. So again, talk to your providers about that. And future, again, continuing with early diagnosis, newborn screening, education, and intervening early so that we can prevent complications. And then hopefully with gene therapy trials, a cure that is available for everyone. So thank you very much.
Wow, that was incredible. And it's so important to be able to recognize, let me make sure that we're not sharing the screen anymore.
There we go.
Wonderful. It's important to recognize, I have a son who is 25 years old living with sickle cell disease. And I can tell you that 25 years ago, not only were none of these available, but it wasn't even on the horizon. That wasn't even part of the conversation. It was, how do you live your best life? How do you help your child to live their best life? Here's the things you should say no to, your child doing. Here's what they won't be able to do. Here's probably, the life expectancy. It was really about kind of just managing the life they were given. And now we literally have options that impact quality of life, that impact our hope, and that not just extend our lives, but also provide a less burdensome life, right?
Exactly.
And that really has to continue to be the goal as we continue to see all of these new therapies coming down the pipeline. We know that curative therapy is not for everyone, and we know that there are some treatments that may not be options for families. However, when we have multiple options, like many other disease conditions, now people can make informed decisions and not emotional decisions, feeling like your back is against the wall. This is all we have. It's not a great option for us, but we have to take it. And there are times that we all will have to do that. But the more options we have, the more options we have. So thank you so very much, Dr. Nelson. I want to make sure that I share with everyone once again that this is the 2021 Living Sickle Smart education sessions. I think you can see that. I want to also make sure that we give special thanks to our partners and sponsors, Be the Match, Bluebird Bio, and Novartis, who helped us to be able to put on this program. And then stay tuned for our future sessions that will be coming. And my screen is not switching, and so you probably can, oh, there we go. Our future sessions this month, we'll also be speaking with Dr. Ashish Gupta, who is part of the Pediatric Transplant team over at the University of Minnesota, as well as we will be talking with some representatives from Be the Match, who has resources for those who will be going through or are thinking about going through bone marrow transplant or even gene therapy. So we'll hear more from some of the pharmaceutical companies who are offering some of these solutions and the clinical trials and the work that they are doing on behalf of the sickle cell community. Each month, last month we talked about sickle cell disease, a public health emergency. As we said, this month is disease modifying treatments and curative therapies. In November, we will be talking about transition and planning for your future, making informed decisions. And then December, we will talk about smiling through the pain and how pain can impact mental and emotional health. So we are extremely excited about that, and we look forward to you joining us. And you can find any previous sessions and future sessions on our YouTube channel or our website, sicklecellmn.org. Again, that's sicklecellmn.org. And then our YouTube channel, you can just search for Sickle Cell Foundation of Minnesota, and you will find many of our videos, past and present. So thank you again for joining us, and we'll see you next time.